Today's topic is all about Letybo. We're sort of steering towards toxins again.
Do you ever mess around with your dilution in terms of how precise you want it to be?
The difference between Australia and Germany is in Germany we have 50 unit vials only,
Right.
which I don't like. There was definitely a learning curve with Letybo.
What does it mean by a non-inferiority compared to some of the other
Talking of resistance, how much of an issue do you think?
It might become at one point relevant. HAs and toxins are like wines, as compared to that. Toxins even more than HA because it's a biological. It's a biological drug at the end of the day. So you have to know this, and you need to know how to pair the wine with the food. I think there are different demands and needs from physician side, from injector side. And then you need to see how the product can work for you. When we moved off-label, as we do in clinical practice, there were some differences to the toxins we've used before. I think most of the people who were kind of those early adopters realized very soon was that the area of effect is smaller than with other toxins. In the beginning, it was like, oof, is that good or bad? The bad is easy. You'll get a relatively decent outcome even if you don't know much. Same for lateral canthal lines. I think frontalis is where you see the differences. Differences in terms of like quality or knowledge or proficiency of the injecting person, but also how toxin behaves.
Welcome to Inside Aesthetics, the world's most listened to podcast for injectors and aesthetic businesses. I'm Dr. Jake Sloan, a facial aesthetic doctor, trainer and speaker with over 17 years experience.
And I'm David Siegel, an aesthetic entrepreneur and business mentor who's been working within our industry for over 2 decades. IA is a podcast aimed at educating aesthetic practitioners from around the world. The information contained within our episodes is general in nature and should not be used by the general public to make health or treatment decisions. You should seek the advice of a qualified healthcare professional in your country and have a bespoke consultation.
For our latest news, you can follow us on Instagram and TikTok, and now you can also watch our full episodes on YouTube and Spotify. All of our links are down in the show notes below. Now let's get into today's episode. Hey guys, welcome to chapter 10 of the Tox Talks. We are here again at the Fresh Life Studio. David, how are you enjoying your conference?
Great. As I said, awesome. I love the place. Great vibe, lots of energy, meeting lots of interesting people. Excited to jump into Tox Talks. It's always interesting to find out more about
our favorite.
Yeah, it's great. Getting to the I'm always learning because I'm not medical, so I love all the geeky stuff and trying to learn about it myself, so it's awesome.
Awesome. And today we've again got Dr. Konstantin Frank all the way from Germany. If you missed our last episode with Konstantin, we were speaking in our masterclass series about the Chroma range of fillers. And if you want to find out Konstantin's full backstory, listen to that one. But Konstantin, welcome again. Thank you for joining us.
Thank you so much for having me again.
It's our pleasure.
Pleasure.
We're having a lot of fun. And we'll be seeing you in Egypt in a couple of weeks as well. You're sort of following us on the roadshow.
Yes, definitely. It's going to be fun. Very interesting.
ICC conference.
Have you been there before?
Yep.
Yeah.
But Cairo especially has like a unique energy.
Yeah.
You'll love it.
Yeah.
It's vibrant.
Looking forward to the gala dinner. Apparently it's outside the pyramids.
Yes, there's going to be a singer. Very famous one, as I've learned.
Yeah.
And this is definitely, I'm going to be leaving before that, but you guys will enjoy it for sure.
Yeah, fantastic.
Good food.
Yeah.
Oh, I can't wait. Now, if you're following us on YouTube or Spotify, you'll see we're out of our studio, but we'll be back in our newly made studio in a couple of weeks' time when we're back from Canada and Australia. In Egypt.
Yes.
I don't know where I am these days now. Now, today's topic is all about Letybo. We're sort of steering towards toxins again. So I guess in our Tox Talks, if you've missed these episodes, we focus on a particular brand and we sort of drill down into how to best use it and how to get sort of the most out of it for our patients.
Yep.
We have actually done one on Letybo when it first launched.
Yeah, Professor Saeed Haq, yes.
Yeah, from the UK. So I guess this is more of a revisit of where are we in 2 or 3 years' time after the experience of launching this new toxin in Australia?
Yeah.
And I guess learning from Konstantin about his best tips and tricks.
Yeah, and before we jump into disclaimer, guys, this is an unsponsored podcast. This is a discussion that Jake and I just wanted to have to find out more about the product. Konstantin's here, want to take advantage of his knowledge and expertise to bring you guys, I guess, the latest information and all the technical stuff. So
absolutely.
Yeah.
Now, Konstantin, if the people missed our last episode together, just briefly, what's your background?
Background is definitely surgical, I would say.
Yeah.
But a mix with anatomy as well. So I studied in Salzburg in Austria.
Yep.
And kind of got into anatomical research back then. And then I did my 4.5 years of residency at the Medical University Hospital of Munich. Went for a 2-year facelift fellowship and breast fellowship to Marbella, Spain,
Yeah.
which was a really good time. Learned a lot. And then I had to come back to Germany for 1 year to finish my board certification because in Europe, they don't accredit all the time when you go abroad,
Right.
unfortunately. So I had to finish this. Board exams coming up. I'm studying.
All right.
Doesn't
Which
sound
is
like he's
hard.
traveling the world having fun.
Which is hard. No, I force myself not to go out whenever I'm traveling and to just study in the plane, which is actually really nice.
Yeah.
Because when you don't buy the Wi-Fi pass,
Yeah.
actually really good to
Digital
study.
detox.
Yeah. You just sit there and study. You can't escape. I hope it's going well. We'll see. But should be fine. I'm now joining a relatively new clinic group in Germany called Elevate Face Aesthetics.
Yeah.
And that's going to be also our surgical focus. Us means there's a good friend and very respected colleague from Sweden coming to Germany. And we're going to be in charge of the surgical department. And we're going to focus on face and breast.
Awesome.
So that's the plan.
Awesome. So how long have you been dabbling with toxins, first of all, before we get into Letybo? What's your
7
history?
years.
Okay. And I mean, I don't know if you want to say, but you've presumably used all of the available ones in Germany?
Yes. Also because I worked in a university hospital, and in the first time in the university hospital, it was like that much of injectables. Much more now in my second university hospital job. In between in Spain, there was obviously a lot, and the clinic I worked in was using Xeomin. Before Munich, we used Dysport and Botox, and then obviously at one point I was introduced to Letybo. I was partially involved in the clinical study, so I got my hands on it very early, and ever since I've been using it, and kind of I think also learned my way to use it. We spoke about this a lot when we spoke about HA. HAs and toxins are like wines. As compared to that. Toxins even more than HA because it's a biological. It's a biological drug at the end of the day. So you have to know this, and you need to know how to pair the wine with the food to get the best result. And it's the same with toxins. So.
I use an analogy of cheese when I'm teaching. So you can start with milk and you can churn it and do all the processes, but you get hard cheese, blue cheese, soft cheese, and whatever. So like you said, you can make different products from the same raw materials. And I think it's important that injectors understand that nuance when they're going to try a new toxin.
Absolutely. And I think understanding then the USP of a toxin is an important thing, and see if it works for you.
Yeah.
I think there are different demands and needs from physician side, from injector side. Then you need to see how the product can work for you.
Yeah.
It should be the other way around, actually.
In our last podcast, we sort of mentioned the relationship between Hugel Aesthetics, who make Letybo, the toxin, and Chroma, who sort of distribute their fillers. And you obviously sort of represent, I guess, both companies when you're doing your KOL kind of stuff. So how long have you worked with Hugel Aesthetics, and where are they based?
Hugel, 4 years now. They're based in South Korea, and it was kind of in the beginning, it wasn't directly with Hugel, interestingly, because I was just focusing on the European teaching of Letybo, which was supplied by Chroma. So as you said, it's a joint venture. Chroma is the HA, Hugel has the Letybo, and they teamed up in different parts of the world. So in Europe, Chroma is selling the Letybo. In Australia, Hugel is selling the Letybo, but having the Chroma fillers. So it's kind of coming from both directions, I would say, and they meet in the middle. So in the beginning, it was just basically not so much interaction with Hugel, but it kind of increased very rapidly. And for me, was a very nice thing because it kind of also opened a little bit the Asian view, Southeast Asian view on toxin. And one of the great benefits of traveling, and this is why I'm still doing it despite being exhausting, is that you can take home so much. And working with a Korean-based company really changed many things, how I think about toxin and how I want to integrate it in my daily clinical practice.
They're very skin focused in that part of the world, aren't they? They're not into the huge augmentation. It's more about skin quality, and
they're getting more and more towards the structural work. I would say, interestingly, they use toxin a lot to actually work on structure. If you think about it, like the body indications they have, it's crazy. Crazy in a positive way. It was really cute. They asked me, I launched the Letybo in Malaysia 3 weeks ago, and they asked me to do a masterclass in body contouring with toxin. I was like, guys, you have the wrong person.
Yeah.
I think I'm not doing this. Like, we actually go to the gym to get a bigger deltoid. In Asia, they try to slim it down. But some Asian patients want to have a slimmed down deltoid, to have slimmer arms. Trap Tox, we do very little in Germany, but it's like a heavy market there. But it's interesting because I think you can take some things home,
Yeah.
definitely with the glass skin. So there you're right. They're doing a lot of intradermal toxin injections to improve skin quality with nice results. Very nice results.
Yeah. So in terms of Letybo itself, I mean, let's talk about what makes it different and unique. I mean, in Australia, for a very long time, we only had like 2 toxins. And then over the last 5 years or so, it's kind of just exploded where we have like 8 or 9 now.
Maybe not 9, but we
Yeah, close to
7
8.
maybe.
Yeah. And so I think that a lot of people don't really appreciate the nuanced differences between the toxins and maybe how to use and how to get the most out of them. So let's just talk a little bit about what you think makes Letybo different.
There was definitely a learning curve with Letybo because the phase 3 study for FDA approval as well, it's been approved in the US as well, was obviously focused on glabellar lines. Very standardized injection schemes, 5 points, 4 units each, with a recon of 1.25 over 50 or 2.5 over 100 in Australia. When we moved off-label, as we do in clinical practice, there were some differences to the toxins we've used before. I think most of the people who were kind of those early adopters realized very soon was that the area of effect is smaller than with other toxins. And this is, I think, one of the biggest learnings of the last 2 years. In the beginning, it was like, oof, is that good or bad? By now, I love it.
Right.
Because it's very precise. For now, I still haven't found a better analogy, so maybe you can help me with that. But I always compare it to like, it's like a sniper rifle. It goes very focused, very precise. I don't like weapons, so I actually don't like to use it that much, but I have no better idea how to.
As opposed to a shotgun.
Thank you. And this is actually the other comparison I use. There are toxins out there which have a very huge diffusion, which is most notably, obviously, in the frontalis.
Yeah.
Frontalis, if you think about it, it's just like a fascia. It's like this very big fascia spanning over our forehead. It's the muscle that's probably hardest to teach how to inject, especially for beginners. Glabella is easy. You'll get a relatively decent outcome even if you don't know much. Same for lateral canthal lines. I think frontalis is where you see the differences in terms of like quality or knowledge or proficiency of the injecting person, but also how toxin behaves. And I've always had a difficult relationship with the frontalis, to be honest. But
I think everyone does.
and mine was shocking.
Yeah.
For the simple reason that when I started dissecting, I never really found it to look like what I thought it looks like. So it was just this flimsy thing, and I was like, I'm just a bad dissector. So when I worked in Marbella, there's this facial plastic surgeon, Luis Capitan, who does facial feminization surgery. And I begged him to come to his OR to see once like a completely flipped over frontalis. And it was the same. It's just a very flimsy small muscle. So that's where it kind of showed that we have a limited area of effect.
And that's kind of, I guess, highlights the challenge. I mean, when anyone is trying to use toxin for the first time or moving to a different product, it's always the frontalis where they fall over. And so you think it's a combination of the nuance specifically with that product, facial anatomy, elevator depressor relationships. It's kind of, it's a multifaceted challenge.
I think one challenge is being the new kid on the block.
Yeah, sure.
That's always a hard challenge for any toxin. So in Germany, I think Chrome was really lucky to have a product manager who had launched Xeomin before. And she knew about the struggles because it was the same situation in Australia. There was only Dysport and Botox, and then Xeomin was new kid on the block. Everybody said, doesn't work, doesn't last, it's too soft. And there are some manufacturing issues. It was like, there's a certain storybook
the same
that is
thing.
unfolded with any new toxin entering the block. And then obviously they're different. And this precision is what requires, I would say, a more profound understanding of anatomy on injector side. How can you get that? Anatomical courses, but also doing a better patient assessment. By now we've created some, I would say, rather good injection pattern for frontalis.
But every forehead's so different, right? I mean, you've got so much, people with larger foreheads, shorter foreheads, different, muscle insertion points and strengths and weaknesses.
The problem is the aponeurosis.
Yeah.
So the aponeurosis is basically a fibrous layer.
Right.
Or a fibrous connective tissue part between the two bellies of the frontalis.
Right.
The problem is there are people who have a frontalis who has no aponeurosis. Those are the ones with straight forehead lines. So show me your forehead lines. Wrong audience. Does it work? You're probably more on the wavy side of things.
A little bit. I tend to get one dominant line mainly.
Yeah, and you're a little bit more straight in terms of forehead line.
Yeah.
That's because you don't have an aponeurosis in the middle. Those who have wavy forehead lines have this aponeurosis in the middle, and then the forehead lines always are created perpendicular to the greatest pull of the muscle. So the bigger the aponeurosis, the more of a lateralization you have.
Right.
This brings two problems. First of all, if you inject centrally, it's not going to have any effect because there's no muscle.
Yeah.
Second problem is those are we call it spook brow or Mephisto brow. How do you call it?
Yeah, the Spock. Yeah.
Spock? Yeah.
Yeah.
Those are the patients that get the Spock if you don't treat accordingly because there's too much lateral pull.
Yeah.
If now the glabella is treated at the same time, also too high, what happens is that they have a drop of the medial.
Yeah.
Everyone just like looks completely
Weird.
funny.
Yeah.
I wonder how many people actually know where the term Spock came from. Like, especially for like new generation injectors, they'll probably never watch like
Captain
Star Trek. Yeah, it's like
He was having this
yeah.
up there.
Yeah.
It's an interesting reference. It's
We're
like,
even more old school because there's like this fairy tale
Yeah.
Faust where
Yeah.
there's Mephisto.
Yeah, it's like the
That's
devil.
what we call the Mephisto eyebrow.
And now we're on video, we can show people this
yeah,
stuff.
I call it like the Jack Nicholson. Yeah.
Yeah.
Going back to your involvement in the study, I think this is really important. So most studies focus on glabella. Sometimes they also on label for crow's feet and other brands, but it's a real problem because you almost have to do the standard 5-point technique to show comparability and so on. And all of the points, I think we can all argue as experienced injectors are maybe not perfect. Some of the lateral corrugators are too high, like you just said. And so we're almost replicating a study that doesn't show us best results.
True.
And it doesn't show us real life injecting.
No, and if you look at the IFUs of any toxin, the injection points they advise, they're just like, wow.
Yeah.
What do you draw?
wouldn't do that in
there's
real
just
life.
like here, and like this is a frontalis injection, friends. This is not glabella.
Yeah.
The problem comes from a regulatory point of view. So the FDA wants to have some safety, duration, longevity data. You also have to take lab values, check for antibodies. So those studies are getting very expensive.
Yeah.
The most expensive thing about any product is not the Fresh Clinics booth or the IMCAS booth, but it's the study itself.
Yeah.
So obviously it makes sense in the beginning to just focus on one indication and go for the glabella because the glabella is also the easiest one to reproduce. You don't get great results if you always stick to this 5-point injection scheme with a predefined dosage, but it works for the study.
Yeah.
I think second easiest is probably lateral canthal lines, then it's forehead. No, platysma, and then forehead.
Yeah.
I think forehead is the hardest indication. And if you look at the studies which led to approval for some other toxins for getting rid of forehead lines, I have a hard time believing that the standardized injection scheme, which in most studies was a 5-point injection scheme, actually led to that results. But if there was not a little extra, I don't want to accuse anybody of this, but you need to be really careful of this. But it's just like, it's hard to get a perfect forehead with a predefined injection scheme.
Yeah.
It's really hard. So they're focused on glabella with the disadvantage that by the moment it rolled out, nobody really had a lot of insight into the frontalis. And this is what I think caused a little bit of a confusion about Letybo, at least in Europe, and I've heard in Australia as well. I think that's also why was dragged around the country. To educate more about Letybo works, because for me it's a really beautiful toxin, especially for lower face. Because it's so precise. I don't want much spread in those areas right here. And I think for me personally, knowing anatomy probably okay-ish, I'm very happy to have a very precise toxin. I can move much closer to the eyebrow, which I can't do with other toxins because out of the fear of eyebrow ptosis. So I get rid of the lines which are much closer to the eyebrow by now, which I wouldn't have tackled before.
Do you ever mess around with your dilution in terms of how precise you want it to be?
The difference between Australia and Germany is in Germany we have 50 unit vials only.
Right.
Which I don't like.
That's like a lot of extra manual work reconstituting.
Yes, it's annoying. You never get a full face with 50 units. Like at least, I know there's a big difference on how much people in Australia inject into a frontalis and how we do in Germany. People were like shocked when I said, you have to use 14 to 20 units. I was like, no, never. We do 6 to 8. I was like, no wonder it's not working.
Yeah.
But you have to reconstitute a lot. It's a little bit bothersome in Germany, to be honest. But what I do is for glabella, basically, I have the 0.625 Reco. It's even more concentrated. For the frontalis, I do the normal 1.25, which gives me 4 units in 0.05 for the glabella. So I have very little volume because I know where my muscle is running. And for the frontalis, I want a little bit more. Something I do for the frontalis as well is that I let them elevate the eyebrow while I inject, because the moment they release, kind of the product gets spread a little bit more. I want a little bit of spread and diffusion actually. So this is a good thing for frontalis from my point of view.
Something I do with my Botox as well. And, you know, when we get these newer toxins that are already made up, you don't really have that choice. You can't do that with a liquid toxin.
Yeah, now people are arguing you can mix it again. It's just like, what's the point of having it in the first
You can make it more dilute,
it then
but you
again.
can't concentrate it.
Like, yeah, you can't concentrate. That's true. I haven't used them that much. I tried 2 of the liquid available ones. And this being said, like I'm not out here to bash any other product. And this is what I said. Just because I like one wine doesn't mean you have to like that wine.
Yeah. I'm noticing a pattern here with the wine. Yeah.
Cheese then.
Yeah. Wine and cheese. Very decadent.
Wine and cheese are very French.
Yeah.
But you have to see what works for you. And
Yeah.
if you feel like there are some advantages in USPs to a product, just like with HA, get trained on it. Don't be hesitant to have somebody come to your clinic. There's no shame. What I feel like is sad sometimes is when I do those master classes and then people do not ask questions. They're afraid to be the stupid one. They're not. Like, it's perfectly fine. Then afterwards, they all come and afterwards I want to leave. But I have to stay to answer the question, which is fine. But like people are afraid to ask questions to get trained, at least in Europe. This is my impression. I don't know about Australia.
Yeah.
I'm sure it happens everywhere, you know.
Yeah.
People have some sort of ego or they don't want to look silly like you said. And, you know, I understand it. But if that's the best time when you've got an expert like yourself, just ask the
Have
questions.
an open communication with
Yeah,
about
you
it.
should just go to the thing. Here are the questions that people ask me after after I finish my talk. Let's talk about them now.
Well, it's a perfect time. Let's record some of these on the podcast. Just going back to glabella and studies and frontalis, and like you said, with all new toxins, they're all quite comparable on glabella because that's what the study has shown.
It's the idiot-proof area.
Yeah, and
Yeah, it's for the most goofy user.
Yeah, I think I could probably do a glabella.
with the study for Letybo, what does it mean by a non-inferiority compared to some of the other brands?
It's a statistical artifact. If you go for superiority, you just need so many more participants to show that statistically. So the gold standard is a non-inferiority study. And this is what, for example, I think also the Korean FDA requires to show non-inferiority against the gold standard, which is the oldest product available in the product test, which is Botox.
Yeah.
So non-inferiority basically tells you that it's not worse than the other, which is mean in a way because like image-wise, it's not good. If you bring a new product and then you have to say from a regulatory point of view, we're not worse than the others. That is kind of mean. You're not allowed to say we're more precise than the others.
Yeah.
We have a really good onset. Like more than half of the patients with very severe glabella lines with a standard 20-unit injection scheme got better. You're not allowed to say that. You're to say we're not worse.
Yeah.
So what kind of impression leaves that to you?
Yeah.
It's not worse. It's
Yeah.
not- so you can't work on the USPs from a regulatory point.
Yeah.
But also at a launch, when you say that, the injectors go home and go, it's the same as X brand. And then they go and use it on frontalis, and it's not. So it's
Exactly,
selling a dream that's not the reality.
And you're right about this. And I think this is a part of regulatory communication problem because officially, like if you go to a company-sponsored event, they're not allowed to speak about frontalis.
Yeah.
So it needs to be off the record and in a non-paid environment.
Yeah.
And this is, I think, where there's the greatest challenge to find a balance on an education that is regulatory fine, from a regulatory point of view fine, and which still gives the information needed to the physician to perform a proper treatment. And I think whenever you look at like big disasters in any industry, it was often a lack of education. Look at Boeing and the 737 MAX. It was a lack of education that happened for those planes to crash because the pilots didn't know that there was an adjustment in the tilt of the rudder. I wouldn't go that extreme with Letybo, obviously, but people are disappointed when they try something new. They get excited. They're told it's non-inferior, so it should work the same, but it does not.
Yeah. Especially when they've got like identical reconstitution.
Yep.
They just, I mean, let's just address the elephant in the room. Like Botox is like the gold standard that was like, it became like the Hoover or the Kleenex.
Yeah,
and so everyone
everyone
compares it to that. So rather than giving each toxin its own respect and working out the nuance of how to get the best out of it, they compare it to Botox, and then I think they treat it the same. And then when they don't get the results, that's when things go
Immediately
wrong.
it's a terrible product when it's not. They haven't used to use the product.
Yes, but you're right. There's a certain question: why should we even have new products when the old one is working? But this is the biggest killer of innovation,
Of course, yeah.
and so it's a borderline walk.
Yeah.
Also, if you think about ethically about it, like how much do you want to invest into studies, into also people getting treated with something unknown if you have already something good existing there?
Yeah,
But now for Letybo, I think the beautiful thing is we got a very precise toxin. That's pretty cool.
yeah.
So this was like an innovation that came to the market. The problem where I think most markets failed and most physicians kind of gave up on Letybo was because they weren't aware of the precision. They expected it to work the same way. And we have a study right now, was done by my good friend Martina Kirscher from Hamburg, which showed the diffusion using anhydrosis areas. And obviously, Letybo had the smallest area
Out of which, by the way?
anhydrosis compared to ONA and botulinum toxin A. So it was a split phase study, randomized. And it's a beautiful study because it really shows the small area of effect. Interestingly, the clinical findings, and this makes us question a lot, were not similar from right to left side, at least for the first 16 weeks. Which is interesting because despite having a small area of effect, apparently kind of knocked out the frontalis. There's one study or one paper out there which quotes that you only have to knock off 1/3 of the synapses of the frontalis. I completely disagree with this because the study, actually I'm a senior author in this paper, but I would have completely do it different now. What you need is a proper histologically controlled study, and you can't have this. But if you compare, for example, corrugator, if you cut corrugator at one point, a lot of its force is already kind of diminished. I don't think it's working that way for the frontalis because it doesn't really have an origin and insertion in a classical way. It's floating in between. By now we know it's not bidirectional. That is something that has been corrected by Jean Carruthers, and I think she's right. It's just like elasticity of the upper part of the skin creating this counter moment. But it's tough for this muscle to get it right, and this is where I think most people fail. I haven't heard about any complaints for platysma, for DAO, for lip flip. It's beautiful toxin.
Yeah, very precise, yeah.
Yeah, it's you're sniper gunning it.
If you could summarize what difficulties people had with frontalis, and including yourself, I guess, and what would they do differently? Like, how would they get the best out of Letybo?
To summarize, the problem was a lack of efficacy in terms of that people came back with forehead lines, specifically in the upper part of the forehead. Often this is most, like, if you look at me, like my hairline's receding by the moment we speak. If like those lines are kind of up here still moving, that's bothersome. It's also bothersome for female patients. So there was a lack of efficacy, not because the product isn't efficient, but because you need to inject it differently. You can't rely on your standard 5 injection point scheme that you have. So what I realized was when I changed the injection pattern to a more distributed one, it became much better, significantly better. And this is how we introduced the Letybo algorithm. So Letybo is a lateralization at the right elevation with balancing and optimization.
Right.
Which means we identify what we would have previously called the line of convergence, which now is just like the most cranial aspect of your forehead movement. And we have certain intersection points at the medial eyebrow, the apex of the eyebrow, and the lateral eyebrow. We place 2 units each intramuscular, whatever intramuscular means in the frontalis, because I don't think we do intramuscular. It's too thin. And then we're checking for the biggest vector. That's our anti-Spock brow point, and I call it the balancing point. It's 1.5 to 2 centimeters cranial of the supraorbital rim. So this is, unless you have a very low rim, then you use the eyebrow. But I don't trust the eyebrow.
Yeah, and they're painted on half the time anyway.
Yeah. That's why I don't trust it. Because I know that's probably where it's inserting around here. So I'm relying more on this. And it's in the biggest vector, 1 unit subcutaneously. That's balancing. And then you have the optimization points up here in those areas of high activity. What's the beauty of the scheme? First of all, it works really well with Letybo because we have more injection points. Second thing that is really important is it's very easy to teach, very easy adaptable, and it kind of hits, and I would say 95% of the patients, the right points. There are some people who have completely anomalous frontalis contraction patterns. You'll fail on those probably with the Letybo scheme. But for a broad patient population, it works really nice, and it reduces the touch-up, because I hate touch-ups. I don't know about you.
It's a time thing, it's a cost thing, it's the inference that you didn't do something right. It's all of that, you know.
And I don't do touch-ups for glabella.
Yes.
Like, rarely. Everybody does it sometimes. But, like, if you look at your touch-up rates, what's your highest? region.
I will always be frontalis.
Yeah, same for me.
We've got a rule on Inside Aesthetics. You can't call it touch-up. It's a dose adjustment.
Yeah, sorry.
Because no, I'm joking. Because patients think touch-up sounds like free. It's trivial.
Or you've made a mistake.
You've made a mistake. It's like, I don't know. I think the perception is, in Europe at least, a lot of people giving away free Botox or free Tox because of this touch-up sort of second event where you get more. Whereas here in Australia, we've tried to make a big effort to make it medical. Things aren't always perfect. You know, you need to be reviewed. And if you need more product, you got to pay for that.
I like dosage adjustment. That's nice. I'm going to use it.
Yeah. I'm talking about it tomorrow, actually. I'm doing a segment on how much is lost toxin costing your business. And
They're expensive.
Yeah. Well, I mean, I was just doing the calculations on, like, you know, if you're just giving away a few units a day, like, what does that look like over the year? And as you said, it comes down to the consultation process. So what expectations are you setting? Particularly, I guess this happens for like new patients when you're getting to know them.
For new patients, there's always a risk because you don't want to scare them off with a droopy eyebrow.
Well, you're better to be conservative, right?
Yep.
You're better off to say, hey, look, this is the first time I'm treating you. I'm going to be conservative. When you come back in for your clinical review, we can do a dose adjustment. And then they go, oh, because you're setting the expectation. Because I think if you don't, they walk out expecting a perfect result. And then there's always a negative connotation attached to that if they have to come back. They feel like something hasn't gone right.
100%. And the thing with, I think, any treatment you do is it's much easier to add a little bit more.
Yeah.
Than take away. It's hard to take away a toxin.
Yeah.
Dose. Like,
Yeah.
if
You have to wait 3 months. Yeah.
That's it.
Tough shit.
There was, we spoke about this, no? There was one idea of like using saline.
So this was trending a little while ago. We discussed it on our What's Trending in Aesthetics episode recently. I don't understand the science
Me neither.
of using preserved saline to reverse tox, but
Oh,
someone
yeah.
has said it. So, you know.
There was a discussion we did with John Joseph around toxin type E that he thought might be good for reversing. But
Yes,
Yeah.
because it's faster onsetting, so it's
Yeah.
going to be competitive to the synapse.
like it
And
knocks
I
off
think
something on the cleavage point or
I think
something.
it makes sense. It might become an antidote to a certain amount. Because it's going to be competitive, and it's shorter lasting.
Yeah. So it knocks it off and then it wears off. Yeah.
But still, most complications we get from toxins by injecting in the wrong places and people not knowing the anatomy.
Yeah.
If you think about eyelid ptosis, did you have one? I had one.
I've had 2 in 17 years.
Yeah, and one was my neighbor.
Oh, nice. Every time you went onto your car.
With my failure every day. You get hectic, man.
One was in my first week, and one was 89 years old. So kind of extremes.
It's bad if it happens, but
Oh, it's always devastating, but you know, you learn from it, I think. Yeah.
the problem is most people don't know why it happens actually. And I think Michael Caine did a very convincing talk for me a couple of years ago.
Well, he's great. Yeah.
I was always thinking about its diffusion into the ventral palpebrae. It's not. It's the frontalis.
Yeah.
A certain amount of people in the population have a certain idiopathic levator palpebrae weakness. So what happens is they're constantly compensating with the frontalis.
Yeah.
The moment you kind of cut off those fibers, eyebrow comes down, eyelid comes down.
Yeah.
And then next time when he comes, you inject probably even higher.
You're following those FDA marks on the corrugate.
Yeah. And then it becomes a very vicious cycle.
Yeah.
So that's something to be careful and mindful of.
Yeah.
Definitely.
You mentioned speed of onset
Yeah.
and duration. So how does Letybo sort of perform?
Median is 3 days, 24, I think 25%, something like this. Don't quote me on it. But like roughly a quarter has an onset within the first 24 hours.
Mhm.
Do you care?
I personally don't. And I think this is
Do your patients care?
No, they've never said, I want a quick one. I want it to work tomorrow.
Well, I hope not.
No. Can always count on David with the jokes. But no, truly, especially for new patients who've never had toxin, it can be quite jarring to get a sudden change in your result and feel that heaviness or that tightness that we all know is sort of a normal feeling with toxin. But to be so abrupt, I think is a bad thing for the new toxin.
I think so too. It kind of is what I tell them is give it 2 weeks.
Yeah.
It's not taking 2 weeks most of the time.
Correct.
I don't
About a
want
week.
to call after 5 days. It's not working. So I tell them give it 2 weeks of time, and then we'll see. Onset for me doesn't matter that much. Like even also as a patient myself, I got injected yesterday.
Right.
It's
You're looking good.
Mhm.
Yeah. Bit of movement, but I suspect that's not your full
but I
motor.
couldn't care less. If it stops working today or tomorrow or the day after,
Yeah.
it's going to stop working eventually. So I don't think that's this. What is more of a discussion is like duration. How long do you want your toxin to last in your clinic?
Well, again, the paradigm has always been 3 or 4 months. So we're conditioned to expect that and kind of want that in a way. So again, with new 6-month ones, if that is real, I don't know how that works. Maybe it will eventually be completely normal, but right now it's different.
I see a niche for the 6 months, a very small one though.
You mean for sort of long distance patients, or
Australia would probably long distance patients, yes, maybe.
but also medical uses?
Medical users, maybe, but it's people who are very busy and who are happy to pay a hefty upcharge.
Yes.
Because what you need to consider is that it's not only going to be the increased cost of the toxin because it's going to be more expensive, but also the lost opportunity for you to do it a third time in the year. You only do it twice a year. So I think it would be like high executives traveling all the time, or investment bankers who just really don't.
Those people are just like, get it
Exactly,
done,
get it done. I'm going to pay double for it. That's fine. See you in half a year.
Yeah.
But then it needs to deliver that half a year. The
Yes.
problem where I see it is, if you have a complication, what you going to do?
Toxin type E.
Yeah, look, if we eventually have the tools, it's not an argument, but I agree. Right now, if you're getting to know a patient, you don't know their face, what they can tolerate, and you suddenly go, oh, sorry, your brows are a bit heavy, that's not good.
It's going to go away in 5 months. Don't worry about it.
Yeah.
That's a little bit what I'm concerned about. And then especially using it with a new toxin where you're not having the learning curve maximum probably at the beginning. So there's going to be an interesting one to observe.
Yeah. So you're talking about duration for on-label, so glabella, or are you talking about frontalis and other areas?
If you look at the duration on label, there are different ways to measure it. Like how do you measure toxin anyway? That's what most people don't know. Toxin efficacy is measured by validated scales. So you basically have like a photo in front of yourself with different glabella line contraction patterns, and then it ranges from 0, which is none, to 1 mild, 2 moderate, and 3 severe.
Yeah.
It's a 4-point photonumeric scale. You can define duration by different endpoints. One of them is time to retreatment. Which is not very realistic because those patients are only scheduled every 4 weeks for a follow-up.
Yeah.
So what's in between?
Yeah.
Then you can, and I think this is the most reasonable thing to do, you can measure it by the time where there is no significant difference. Oh, no, sorry. It's the last time point where there is still an existing significant difference in the response rate between the toxin and the placebo, which for the Letybo was 16 weeks for the glabella, which is in line with what we have out there. For the frontalis, in those studies we've done, it was around 3 to 4 months.
Okay.
So for me, that's reasonable. What I wouldn't like to have is a toxin which stops working at the frontalis after 2 months, but the glabella keeps on going for 4 months, because then you have an issue in terms of like timing. How are you going to do it? I usually don't like to, and this is why I don't like dosage adjustments. Like I have them as well. Like there's no need to.
He's already using the new term.
Yeah,
it's already in the vocab.
Flavor for you.
Yeah, there you go.
But even though the risk is really small, we always have a little bit of risk of resistance. And I think the resistance gets boosted by if you do those dosage adjustments more frequently, or if people are not in line with their treatment. So some patients, for budget reasons, get the glabella on one appointment and then the forehead on the other one. That doesn't make sense. Like I sent them home and said, save up and then come back.
Yeah.
Because I'm just going to not do you a favor.
Yeah.
This is really important to consider at the back of our minds.
Yeah. Talking of resistance, how much of an issue do you think it is? It's become like more spoken about. You know, I wonder if there's like a placebo effect with people kind of almost like wish it into existence, and it becomes, because it was COVID kind of kicked it off a lot, you know?
I think in aesthetic, for the aesthetic use, it's a very small, tiny risk. If you go into the like really therapeutical use of toxin where they get huge doses, it might become at one point relevant.
Yeah.
I've seen 2 people with resistance in my life. One of them was coming from Russia. They had an endemic case of botulism in the village she grew up. Actually, people died of it because the water was poisoned. She had resistance to it, and I believed her. Yeah. Then there was one who was one of the first patients of Gene Carruthers, then came to Marbella for a facelift. We tried any toxin out there, and none of them worked. We did a corrugator excision, like surgically.
Oh.
And then it came back. It was like the godfather of glabella lines. We didn't defeat it. Then I have a lot of patients who have resistance to get a higher dosage.
Yes.
Like that's a thing in Germany. Like they go, I'm a little bit resistant to it. I need more because I think if I double the dose but charge them the same, it's going to last longer or give them a better result. It doesn't. but you have those people claiming it. In what can I say, like in regards to Letybo, because this podcast is Letybo related, there were antibody assays in all of the 1,200 patients involved in the clinical study of Letybo for glabella over a course of 2 years and up to 4 doses. They didn't have any formation of antibodies. And even if you have antibodies, doesn't mean that it becomes clinically relevant. So that's the next thing. I think it's a nice storytelling, which is driven by some parts in the industry.
Some brands maybe.
And I think in therapeutics, it has its justification. I'm not an immunologist, so maybe I'm just like not aware of how severe the situation could be. From my clinical judgment, I don't say it's a day-to-day issue that we have. Do you agree, or do you?
I totally agree. I've met one who I truly think, okay, you're resistant from what I can see. I've never seen it otherwise. So yeah, it's pretty rare. When you're swapping patients from potentially one traditional brand to Letybo, I don't know if you did that in your practice or, you know, they were already on Letybo, but do you have any top tips to sort of communicate to your patients, not just what you're doing, but why you're doing it?
Really hard question, because it's like a for and against.
Yeah.
The moment you tell them you're changing something, they will realize something, which is probably not really happening.
Yeah.
Placebo,
it's just like, oh, it hurts more, or it's. I think we had this discussion last week when we went for a cup of coffee. They said, like, ethically, you should tell them you're right about this, but in all honesty, like, they don't know what I'm injecting anyway.
Yeah.
Because in Germany, people just frankly don't care. Even with regulars, I have a hard time explaining the difference sometimes from toxin and HA.
Yeah.
It's not like they don't care. It's like we try to educate. I think they don't care. They just care about the result.
Exactly.
So it's not a B2B market in Germany. Allergan has tried with, I would say, little success. They tried to get some testimonials to advertise that they had Juvederm injected. It probably helped more the doctor who injected it than the brand, because my patients, or any patients in Germany, there's a huge trust on the person performing the procedure. And I prefer this. I prefer my patients having like kind of the trust in me, like putting the right stuff into their face, than patients relying on the, like, they should rely on the product, don't get me wrong, but it should be my decision. In other words, if you go to the hospital and get an antibiotics, do you ask them if it's from Baxter or from Johnson & Johnson? You don't.
I agree with that, but I will challenge it. So we've, in our previous podcast, we were sort of saying that breast implants are analogous to implants of the face, like fillers.
Sure.
And, you know,
I know what's coming.
I wish there was a day where there was a global app. Every patient had it on their phone, and there's traceability. This is what's in your face. Here's the batch number. Here's where it came from. It's real. It will get rid of all the black market rubbish.
We have this traceability to a certain amount in Europe now with MDR. There is a code. We have those leaflets. We have to go to the patients. In the electronic patient chart system of the clinic I'm joining now, it is actually with the barcode.
Yeah.
Put in. It's not centralized where you have an app.
Yes.
I think companies should work on apps. It would make life much easier.
Yeah.
It will also be a nice advertising marketing tool in a way, to be honest. Like if you have your aesthetic pass or something like stuck in your wallet. Because patients lie.
They forget.
That's what I just like. They're not lying because they want to lie, but they forget about. Like whenever I do, consider, did you have anything that? No. I see the scar.
Oh, but when I was in Lebanon, someone did something. I have no idea what they did.
I see the scar here. It's like, no facial surgery. It's like, no, you did have a facelift. Yeah, that. And I was like, okay, how much more invasive than a facelift does it need to get for you to remember, right? But I think it doesn't matter, and that's fine. It's our job to find out. We have to be the detective. Still, I think if you think about implants, for example, people are much more aware of which implants we put into them than which filler we use. Yeah, Motiva is a really good example. Like, people love Motiva in Germany. They want Motiva implants. They want the ergonomics implants, even though they sometimes don't make sense in them. It becomes hard then to convince them. That a different product might actually be better for them. So it's a back and forth. In China, for example, people go all for the brand.
Right.
The companies advertise the brands heavily in their hospitals, and people go for
the name
chroma volume injection. It's just like you go for an Armani shirt or a Zegna shirt, they go for a chroma injection or for an Allergan injection.
So they can advertise direct to market. Yeah. Okay.
So I don't think it's a good thing, because I think it should be your responsibility as a doctor to choose the right medical device or the right drug for your patient.
Well, it's
almost showcase your skill as well. It's not about the product. I mean, it is, but It's how it's used,
Well,
right?
it's kind of taking the physician's choice out of the situation, because you've got the company marketing directly to the patient, and so it sort of short circuits like your capacity to make the decision as the practitioner.
True, definitely true. And this, I'm not sure about if we should go into that direction, to be honest. I think it makes more sense to kind of keep it in the physician's hands.
Yeah.
And then the patient can decide. But yeah, what with the traceability, for example, with implants, it's nice. We will never be able to do it with HA, but with Motiva, you can scan the breast. It tells you which implant.
Oh gosh.
Yeah.
That's pretty cool. But yeah, we'll never get that for fillers, obviously.
Yeah, fair. You mentioned that Letybo seems to perform better because of its less diffusion in off-label areas like lower face. So tell us about your experience with that.
I would be careful with better because I don't have clinical.
Less inferior.
No, less inferior is a little bit grim. More precise.
Yeah.
Based on this precision, I feel I get better results. I have very less diffusion to depress the labia inferioris, but you need to know where you have to inject. For masseter, in all honesty, I don't think it really matters because it's just such a big muscle.
Mm-hmm.
Diffusion here or there, no, doesn't really matter. Same for temporalis, which is becoming an increasing target for off-label use in Germany.
Yes.
For platysma, it works really well, to be honest, as well. I think it does really well. I don't know if it does better, and I wouldn't go as far.
But you have a low complication rate. Yeah.
Very low.
Great.
Decreased to what I've used before.
How do you do your masters? What's your technique? Everyone wants to know.
I do 3-point injection techniques, one very deep, one intermediate, one like not superficial, but like within the muscle, a little bit more superficial because I want to kind of hit the deep part. I let them clench and bite. I palpate the muscle. I feel many people are not palpating that much anymore. They're just relying on the optics of it. But
Like a bit weird.
yeah, but you have to palpate. You really need to find it. Then I draw one line at the anterior border, one line from tragus to modulus. That's my upper limit.
Yeah.
And then I always go 1 centimeter back. So I don't want to have the risorius involved. I had it once.
It's a shocker.
It's not funny.
Yeah.
The problem with asymmetries with toxin is like, I do you treat asymmetries? I don't anymore. I tell them it was asymmetric, it is asymmetric, it will be asymmetric to a certain amount, because the moment you try to chase those complication asymmetries, just get. I did it twice, it just got worse from there.
Yeah, I do for facial falsies, but not for, just normal asymmetry. Yeah, I don't really chase it.
Yeah, you're chasing yourself then.
Yeah. And I also make a big song and dance out of pointing out the natural asymmetry to a patient's face when I first meet them, so they don't go and scrutinize it and worry about it's normal.
Yeah, and I think you have to make people aware of their asymmetries.
Yeah.
It's when you look about breast surgery, they never notice how asymmetric a breast is up to the point where they enter the OR or step out of the OR.
Yeah.
So this is where photography helps a lot.
Totally agree.
Yeah.
Same for toxin.
What about combination treatments? I mean, that tends to be spoken about a lot lately in terms of like combining different products, procedures with each other. So, in particular, you said you like polynucleotides, skin boosters, HA, a lot, especially being a South Korean thing, like using it to treat like pore size and so on. So yeah, what do you
to
do?
get a really good result, you need to combine.
Yeah.
By combining, I mean treat on different levels. Treat the skin, treat the sub-Q, go for the deep volume augmentation, and when there is a need for a lift, do a lift, which means surgical. Just because you add volume doesn't mean you suddenly don't need a lift anymore.
Yeah.
And this also we've learned from breast surgery.
Yeah.
Implant won't compensate for ptosis.
Make it
It's the
worse.
same as
Yeah.
this. It just makes it worse. What I don't do is in syringe or in vial combination, which I think is completely absurd at this point. And we have this big trend of people mixing CAHA and HA and then injecting it, and they advertise it like you have to make it foam, and it's just like this is basically an emboli you're putting into the subcutaneous tissue. That's air. You shouldn't do that. So I don't mix any products. I don't think it's clean. I don't think it's necessary. Maybe back in the days, when you only had like one Juvederm filler or one Perlane back in the day, you used to stretch it with a little bit of saline to get it under the eyes. Okay, fine. But these days you have such comprehensive portfolios in all product classes that I don't think there's any need for us as doctors to kind of do this whole alchemy.
Yeah, like potions.
I think that's a really good point. There's levels to being off-label. Treat a different muscle that's not in a study. Okay, we've got long-term anecdotal and case studies sort of showing that it works. But to make your own product, I think that's totally...
Yeah, and then there's also like the medico-legal implications. If something goes wrong and this ends up like litigious, where does that put you as a practitioner? You know, like if a lawyer was to ask your colleagues, you know, what do you think about this?
Yeah.
That's when you can sort of run into problems. So I guess, like, you know, where's the line between, you know, having the freedom as a healthcare practitioner to go off label and to use your judgment and expertise versus like just becoming like a mad scientist?
That's the point. And like, I'm not a rheologist. I'm not a product manufacturer.
Yeah.
There's absolutely no need for me to alter something in my office and add a little bit of sprinkles of voodoo or whatever. Like, no.
Do you explain to
Got a chicken there.
Yeah,
that you're going to do something off label, be it masseters or
I have to. They have to sign on it from a legal point of view, and I think it's fine. I just tell them, listen, the product is not indicated for this.
Right.
You have to sign off on this, and they don't mind.
Yeah, I think it's important in the consent process to explain that.
You have to include it from my point of view in the consent. Like in Germany, we're really lucky. We don't have a lot of litigation going around plastic surgery or minimal invasive stuff.
Yeah.
People are pushing it a little bit right now.
It's very much a Western thing. America, like Australia. So it's very, everyone wants to sue everybody for everything.
The surgeon, you know? It's like, but we don't have it. In Germany, we have a culture of that, like colleagues, unfortunately, are kind of bashing each other. This is, I don't know what's worse.
It's everywhere, not just Germany. Yeah. It's human nature globally, unfortunately, at the moment. So.
Now, from a business standpoint, I don't know what costs are in Germany or other countries, but you know, Letybo is sort of more cost effective than maybe some of the more traditional brands in Australia, which is really appealing. And
especially these days,
business mentoring, you notice a lot of people move to Letybo for that, I guess, saving, if you like.
Yeah, I mean, and that's the challenge. If you can get as good or better clinical result, then you know the finances do play a big part, particularly as the industry becomes more competitive. It's becoming more saturated, and so people are now starting to pay attention, as they always should have, but now even more so, like their finances. Like, what difference is this product going to make to my business?
No, that makes sense.
Yeah,
this is a big part of the equation. We all need to earn money at the end of the day. We don't do it for love and air.
Not alone. Not alone. Not alone.
Yeah. I do it for the kids. I think then there's a challenge to position something as not cheap.
Yes.
And I'm coming from a part, like actually my grandma's coming from a part of Germany that is very notorious for being tight on the money. Stuttgart, like Porsche and Mercedes, a certain vibe to it, like keep it. And but she taught me one thing: nothing is more expensive than cheap.
Yeah.
And I think this goes very well also for product placement. Don't make something too cheap, because I would like to have something too cheap. I want it to be cost effective. That's
it's value.
Yeah, value. Exactly.
Yeah.
The biggest mistake that at least I observed is people moved to a more cost-effective product, but they don't learn how to use it yet.
And then they're disappointed, and then it gets a reputation. Oh, wow, it's cheap. It's not. Yeah. You know, it kind of and it becomes a vicious circle.
Yeah, and with this industry is notorious for like Chinese whispers, and people like have all of these assertions and opinions on a product that they've never tried because they've heard about it from a colleague.
But this is something really important. Where also I think we as I hate the word QL, as I said before, but it's just like we're not asked to take any other companies to town and any other products to town. We're here to share about our experience with the product, where it works for us. Yeah. And I think it should end there.
Yeah.
There's no need to bash anything. It's like wine.
Back to wine. I guess truthful answer, do you carry any other toxins in your fridge, or is it just Letybo?
We do.
Why would you choose other ones?
Because the clinic I'm joining is having a big account with a different company right now.
Okay. But it gives
so that's not a clinical decision, it's a business decision, probably.
Yes. And none of the doctors has used Letybo so far. I will.
Yeah.
So.
Well, that wraps up this episode of the Tox Talks.
Yeah.
Constantine, that's
thank you so much.
Great
Thank you
to learn from your experience. And
looking forward to see you guys in Cairo then.
Yeah, it'd be great. Yeah.
Have a lot of fun dancing in the desert in front of the
on a camel.
Giza.
On a camel.
Watch out for the story on Instagram. Mate.
Yeah. Thank you. Safe travels, and we'll look forward to seeing you soon.
Thank you. See you in a couple of weeks.
See you soon. Bye.
We hope you enjoyed that episode, guys. To stay up to date with our latest news and episodes, follow us on Instagram, and we're now on TikTok.
You can also now watch our full video episodes on YouTube and Spotify. So if you like what we do, please give us a like and subscribe. Please also consider joining our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, hints and tips videos, bonus podcast content, and more.
All of our social links, Patreon and contact information are in the show notes below, and we'll see you in the next episode.